Hi dear friends and colleagues, I'm excited to share to you a very interesting case in my opinion. Let's start. A 17-year-old patient was referred to the clinic for endodontic treatment of tooth 16. Clinical examination revealed no pain on palpation or percussion, and tooth mobility was within physiological limits. Periodontal probing showed a pocket depth of 3 to 5 mm, with a localized deepening for up to 8 mm in the area of the mesiobuccal root. Additionally, a small abrasion zone was noted in the cornal third of the outer surface of the mesiobuccal root. The cold test yielded a negative result. Radiographic examination revealed a radiolucent lesion approximately 3 mm in the apical third of the mesiobuccal root. Based on these findings, the following diagnosis was made: pulp necrosis and chronic apical abscess. In first appointment, a conservative access cavity was prepared and root canal instrumentation was performed using CM-wire rotary instruments. EDTA and sodium hypochlorite were used as irrigating solutions. To enhance disinfection, passive ultrasonic irrigation and the XP endo finisher were employed. During the procedure, 3 mesiobuccal canals were identified. Here I want to pause and ask a question. How often can we identify 3 mesiobuccal canals in the first upper molar? Let's discuss about it. In a study by Kim and Chang, 154 first upper molars were examined. After disinfection with 3.5% of sodium hypochlorite, micro-CT imaging was performed. 2 classifications were used for the statistical analysis of morphology: Wayne's and Vertucci's. However, Wayne's classification was ultimately rejected, and there is a reason for this. Wayne categorized the morphology of the mesiobuccal root into 3 types. Type 1, a single oval orifice with a single root canal. Type 2, 2 canals emerging from the chamber floor that merge at the apex. And type 3, 2 separate canals with distinct apical foramina. This classification was insufficient to properly categorize all observed anatomies. As a result, Vertucci's classification was used instead. Type 1, a single oval orifice with a single root canal. Type 2, the same as Wayne type 2. 2 separate canals leave the pulp chamber and merge short of the apex to form 1 canal. Type 3, 1 canal leaves the pulp chamber, divides into 2 within the root, and then merges again to exit as a single canal. Type 4, the same as a Wayne type 3. 2 separate and distinct canals extend from the pulp chamber to the apex. Type 5, 1 canal leaves the pulp chamber and divides short of the apex into 2 separate and distinct canals with separate apical foramina. Type 6, 2 separate canals leave the pulp chamber, merge in the middle part of the root, and then redivide short of the apex, exciting as 2 distinct canals. Type 7, 1 canal leaves the pulp chamber, divides, then rejoins within the middle part of the root, and finally redivides into 2 distinct canals short of the apex. And type 8, 3 separate and distinct canals extend from the pulp chamber to the apex. As a result of the study, type 2 was identified in 23% of cases, type 3 in 10%, type 4 in 19%, type 5 in 9%, type 6 in 13%, type 7 in 5%, and type 8 in less than 1% of teeth. Additionally, 17% of the examined teeth did not fit into any of Vertucci's classic classifications. This highlights the variability of the root canal system. Even today, we're still unable to clean, shape and obturate such complex anatomies. A few words about the frequency of mesiobuccal third canal. Recent studies suggest that MB3 can be found in 30% of cases using micro-CT. It is typically located between MB1 and MB2 and merges with MB1 at the depth of approximately 6 mm. So, when can we identify three separate canals in the mesiobuccal root? The canal anatomy like this may be caused by pulp canal obliteration. According to the study by Syke and Reed, calcification was found in 90% of teeth from patients aged 45 and older. A significant difference was observed. The caries young group exhibited 5 times more pulp calcification than the non-caries group as well. Age-related tooth wear, including attrition, abrasion, erosion, and abfraction, along with prosthetic interventions in vital teeth, can contribute to partial or complete pulp canal obliteration over time. Let's return to our case. A radiolucent area was observed in the middle third of the mesiobuccal root on the radiograph with glutopercha, which could indicate resorption. I was also concerned by the unusual direction of the glutopercha, which did not follow the natural curvature of the canal. Given these findings, a temporary calcium hydroxide dressing was placed for 1 month. The patient was referred for CBCT to further refine the diagnosis. CBCT findings and treatment plan adjustment. CBCT analysis provided additional clinical insights. The most significant findings included both mesiobuccal canal configuration. It was Wines type 1, a long oval-shaped canal, root divergence resembling a primary tooth. Suspected root resorption in the middle third and external root resorption in apical third, possibly indicating trauma during root development. I want to point out that the radiolucent area in the middle third, which was visible on the parallel X-ray, was not seen on the CBCT. It was due to an unusual anatomical formation of the root canal in the middle third. This is one of the reasons why CBCT should be performed in complex cases, as it can provide clearer diagnostic information. But that is a discussion for another time. In second appointment, the patient returned the following months. The calcium hydroxide dressing worked well in the root canal. As is well known, calcium hydroxide maintains a high pH level for up to 28 days. By the way, I am part of the team of endodontists conducting an interesting study on calcium, and in a primarily laboratory study we obtained new data on both the pH of calcium in root canals and the accumulation of calcium ions in the root dentin. Let's continue. The temporary dressing was removed and re-irrigation was performed using EDTA and sodium hypochlorite, activated with XP endofinisher and passive ultrasonic irrigation. Isthmus enlargement was deemed and justified in this case due to very thin root walls and the risk of losing precervical dentin. A bioceramic sealer was used as the obturation material, and the root canals were filled using the passive lateral compaction technique. The postoperative radiograph showed an interesting obturation pattern. As is well seen, the sealer wasn't filled all complex formation. The patient is scheduled for a follow-up examination in 6 months. Thank you for your attention. I hope this case review was interesting and useful for you.